So, to the spotlight conversation. Our speakers already given names, but Bevel, Secretary to the Federal Minister for Economic Cooperation and Development, and from 2016 to 21 served as Federal Government Commissioner for Human Rights and Humanitarian Assistance at the Federal Foreign Office. Natalia, our amazing, vibrant and dynamic Executive Director at UNFPA, and similarly Dr. Awa Sek, who's just been so involved in so many ways in global health, rollback malaria, UNAIDS, as Minister of Health in Senegal, and still to this day, a minister advising Macky Sall, the President of Senegal, as well. So, the fireside format. I'm going to start with Natalia and ask you, Natalia, from COVID to Ukraine to Pakistan, we see that the health and well-being of women, children, and adolescents, not least women who are pregnant, not least newborns, not least
landscape. These are things that we can attend to. And then lastly, if the quality of care can be addressed, it's very important not to have people feel defeated. Okay, I walked my 3 hours, now the door is locked, or they don't have the choice of contraception that I would prefer, and on and on. So it's the poor who suffer. And I think women and girls as that subset, when the indignities include extortion and sexual exploitation and all manner of service delays, et cetera, this is going to affect your willingness to leave where you are and seek care. So the bottom line is access to quality sexual and reproductive health care services. It is part of human rights. It is part of bodily autonomy. And I would like us to pre-position and pay attention to planning so this aspect of well-being can be. Thanks.
Thank you so much, Natalia. Let me come straight to Minister Awa Marie Colsec. Awa, in the last couple of years, we've seen this devastating impact of COVID in many ways, and not least on the health and well-being and health services of women, newborns, and other vulnerable groups. Would you like to tell us a little about impacts in Senegal, and also what, in the face of the multiple crises the world is now experiencing, is needed to see that essential health services, including sexual and reproductive health, are restored and maintained?
Thank you, Ellen. I would like to thank also the organizers that I am very happy to have in this panel yourself sharing it. And we know each other for a long time, and I have always been very happy to work with you. But we have also esteemed really friends, but also people fighting for women's rights and also for gender. And thank you, Madam Minister of State. Thank you also, Natalia. I know that you have done so much, and I would like just to tell you, Ellen, that what we have seen when we had the COVID pandemic in Senegal, it was first a direct impact. A lot of people here know that COVID in Africa has been less common than we have seen in the north. But because our system is very fragile, and the country is also economically more fragile, this has been very strong impact in the community and in the population in general. And what we have seen for women is that they were at the front line at community level, front line in the structures, because they were the one in charge. You have more women in the system than men. It is why the first who have been really shocked was the women themselves, and we at the front line, but also at home. They are the one who are taking care. And this is why we cannot speak on COVID pandemic and medicine without taking into account the human and the gender issues. But also, the other point I like as what we have seen is the health system has been completely disorganized. We had already problems, but it was worse because we had a lot of patients coming to the structures, and at the end of the day, a lot of people were able to have care and structure. They didn't go because they don't have no place. Because the urgency was to look at the patients with good. And this is why we have seen this, that people are saying the second type of epidemic, which was that the women, the children were not really taken care of. They were out of the system. And as you say, Natalia, I will not come back to that. Women were not able to go to because they are pregnant. I've seen a lot of decrease of women not being able to go to their antenatal care or deliver, because at the time they won't deliver, it has no place, etc. But also the structure was had very important financial impact because nobody was going to pay, the insurance were not working, and themselves were not able to take care of the patients. It was all COVID. At the beginning, it was like that. But we had some, I will
finish by that because we had some capacity, particularly a platform we create with all the partners and particularly facilitated by DFF, where all the international partners were there, but also at local level in the Ministry of Health, with the Ministry of Finance, the Ministry of Education, Ministry of Women and Gender. We had a lot of work done already. And this has helped. If not, we would have been in a difficult situation, more difficult than what we have seen in Senegal. I would like also to say that women was also impacted because economically more fragile and working more in the informal sector. And there, you know that when you have a problem, the informal sector is the first who had to see how to do. And a lot of them were selling things in the corner or going, when we shut all the possibilities for them, they were at home. And this was also a big problem because people have been fighting to empower women, but you empower women, but they are not able to go out to do what they have to do. And this is also another impact I would like to highlight. My last point will be maybe to look at also young girls at school. And what we have seen is that the program for HPV were delivered at the level of school has been closed. And they didn't have any more access to vaccine. And this was for Senegal also. When you look at the young girls, another problem we have. The children didn't have chance to go for immunization. Senegal was one of the countries where we are all around 95% of coverage for the immunization for children. But we have gone down a little bit, maybe for 4% or 5%, but we went down. And this has been seen in a lot of countries too. We didn't have epidemic and things like that, but we have seen it in other countries. Ellen, I would like to stop there because when you are asking me to speak on Senegal, I cannot stop, but I will stop.
Well, thank you, Awa. You've given us, real life experience on what actually happens when services are disrupted, and thank you so much for that. Now coming to Bebel Kofla, what place do sexual and reproductive health and rights have in universal health coverage reforms, and how can we make sure that UHC is linked to gender equality and to always supporting and advocating for the position of women and girls?
Well, thank you very much for that question. And first of all, I want to thank my fellow panelists for being here. Thank you that you were accepting the invitation, coming to Berlin and sharing your insights with us, Madam Minister Natalia. It's a pleasure to have you here. And it's also a pleasure to have all of you here because it's showing that so many people are interested in that topic. That's already part of the political way we have to go to make sexual reproductive health and rights a real big topic, a political topic, a topic in public. And what we're doing here is also working for that. So for us as the BMZ or in the German government, it's a part of our feministic development policy, feministic foreign policy, because we want to put the needs of women and girls in the center of our policy. And therefore, of course, sexual and reproductive health is of big importance. It's about, you were describing that perfectly, access to medical care during the process of delivery. It's about childcare, but it's also about family planning. It's about the whole needs for women during their life circle. And well, we are trying to put also a focus on a systematic discussion. It's about access to health systems. The one thing is to create health systems in the countries, but the other thing is to have access also in remote areas, but on the other hand, also for poor people. So you need also some kind of a minimum systematic financial approach for basic needs all over the globe. So if it's coming to universal health coverage, I think we have to think about the social protection issue very much, and that will then also benefit or give support to the women Because what Madam Minister was pointing out is quite right. At the end of the day, it's not only about health, it's about economical empowerment. It's about the question if women then have the position in their families, in their areas, to be real independent, and therefore then at the end of the day have access again to health, giving this knowledge to their children, to the girls. So it's a cycle. So working on 3 levels: political level, coming up the UN declaration to negotiate. So we're trying to achieve that there are really strong comments on sexual and reproductive health and rights in that. That's we will work on that. We work with our partner countries and with friends on the multilateral level, also on the systematic approach I was pointing out, access to health on various different angles, which I think is very important. I see that in all my travels around the globe. It's always at the end of the day is, can I afford it? Can I reach it? And can I afford it? Is it there? Can I go there? And can I afford it? And we are working on our bilateral programs also on very practical issues. So we try to cover all those 3 layers. One example, which is interesting, but it's only an example and we shouldn't take it for a solution for everything. We're working with Kyrgyzstan, for example, for creating an app for midwives to reach women in remote areas. Of course, you need a lot of things. You need electricity. Yeah, you need a lot of things. It's not the solution for everything, but I think we have to think a little bit out of the box to come up with practical solutions who can work in various contexts. So that's the 3rd layer of political engagement we have: political, systematical, and the very practical programs at the end of the day with our partners, multilateral, European, and bilateral programs. And at the end of the day, it's about empowerment of women. So you won't change the health system or access to health for women if you don't change the role of the women in their society. So it's about empowerment of women at the end of the day. And that's what we're really working on. And that's why I'm so grateful that we have those 2 panelists, for example, here also.
Thank you so much. Coming back to Natalia, so it's clear to all of us that sexual and reproductive health needs to be part of universal health coverage, and a lot of services, particularly when it comes to maternal, newborn and child health, are. But what about other aspects of sexual and reproductive health and rights, whether we're talking gender-based violence, services for young people? What place do they have in processes to achieve universal health coverage? And can we really say we've achieved universal health coverage if we don't cover a comprehensive range of services? Natalia.
Well, Helen, let me match your question with a question of my own. Is it possible in the realm of imagination for any country to achieve universal health coverage without sexual and reproductive health and rights?
No.
The question is rhetorical and the answer is no. Because poor sexual and reproductive health accounts for roughly 1/5 of the global burden of disease. And any argument against incorporating SRHR under UHC is effectively an argument against women's health and well-being. The sexual and reproductive health services are not nice to have. These are really essential parts of saving lives. And of course, I think you go country by country, it doesn't really matter. These issues are difficult to speak of. It's family concerns, it's human intimacy, and they shouldn't be swept under the rug, under the guise of a patriarchal concern. It's discriminatory when we do that. So I would say that we have to position SRHR as one of the dimensions of universal health coverage. And when we think of the 4 pillars, the universality, the equality, the quality, which I spoke to earlier, and financial risk protection, over and over, while it might be easier said than done, we have to look to communities. We have to ask women what they want, and we have to respond accordingly. So I would say that while there's been progress, we still have to emphasize that half of the world's population of women cannot decide on contraception for themselves. They can't decide, I'm going to get up this morning and leave the house and go around the corner to my health facility. If husband, partner, son, whoever doesn't say that it's allowable. So I emphasize family planning, but I also have to ask all of us to think together about things that prevent us being truthful with young people in adolescence, in an age of fertility. When I talk about maternal mortality, the woman who dies is a girl. This is a girl who barely got to be a teenager and she's pregnant. And is this volition? Is this consent? Is this, it happens every single day. And we have to address comprehensive sexuality education. I have to say UNFPA has no favors with the jargon that comes with sexual and reproductive health. So how do we break down comprehensive sexuality education so the parent is reassured rather than threatened that the girl child needs this information? And by the way, the boy child does too. For safe abortion services, politically very charged to discuss, but a lot of death in SRHR comes from unsafe abortion. Our State of World Population Report revealed that half of the world pregnancies, 47% for the technical people, are not planned, they're not intended. So what do you do with that? Again, women's rights to choose. I believe that we're at a time now where gender-based violence, female genital mutilation, thanks to people like Awa Marie Kolsek, we've made a dent into some of this, but we have to get to a point where everyone knows child marriage is wrong. It's not a marriage. Everyone knows that you cannot beat your wife. I mean, what century are we really existing on? So prevention, detection, management, empowering midwives, all of these are themes that have to do with how we're going to make UHC better. Reproductive cancers, the morbidity and the causes of infertility. Again, we've got to look at the whole spectrum, right? And if you're a poor woman who wants to avail yourself of infertility services, good luck. The expense is standing in front of you. So I'll just end by saying that we are really speaking of health as a human right, not as something that I give to you out of my generosity. It is your human right. And for the better than half of the population who are female, should not be left behind. So I hope that we can build those channels for involvement. I think it's exciting to sit here and realize that we actually have made a difference. Yes, we have further to go, but we have to work on these issues. And I'll just close again by saying there can be no universal health coverage without universal sexual and reproductive health and rights. Thanks.
Definitely. Now, we're right up against the time allocated for this great panel, but I know both Awa and Babel have very important points to make. And Awa, to you, your president, Macky Sall, hosted the Global Financing Facilities Reclaim the Gains campaign. Can you tell us a little bit about why it's important for your country and for the GFF to be supporting countries to ensure SRHR and reproductive health really are prioritized as we strengthen our health systems?
Very quickly, President Macky Sall from Senegal has been honored to really be the co-chair with Prime Minister Trudeau of the campaign for GFF because replenishment. It was not because he wanted only to be part of the story. He did it because we have an experience in Senegal and in a lot of other countries in Africa, showing that it is very important to work together. And it is the story of the platform I was referring to before, but to ensure that countries are on the driving seats. And it is often said, but this needs to be a reality. And this has been a reality when we have started to work with GFF and to know that it was important for everybody to have a voice. And it was what I've said, the international community, but also the national community, and particularly the civil society. It was not only ministers, etc., but all the NGOs involved in reproductive and sexual, reproductive health and sexual reproductive health globally was involved, because before they were all working in silos and the Minister of Health sometimes were not aware of what happened. And this was an opportunity. And I have the chance at this time, I was Minister of Health, and I can tell you that we were in the driving seat. It was not something coming from elsewhere. We look at our business case to know what we want, what are our gaps, etc. And at the end of the day, it was really our program. It was something we own. And this is very important. And it is why the president accepts also to be part of that. I would like also to say that we created an environment where it was in an holistic approach. It was not a vertical approach of the Minister of Health only or the Minister of Education. We were all working together. And this has been also another big advancement for Senegal. And what we saw also is the flexibility of this initiative of GFF, because, for example, when we had COVID, the people we have trained for reproductive health has been used and trained again for COVID. And they were the one at community level were able to speak with the people. And this is really, to be short, why Macky Sall has accepted to take the lead on this. It was because it was a Senegalese experience, but also an African experience. And we know that this has existed in other continents. And it was why it was important to do that. We did it. We had succeeded, but we had gaps. And it's an opportunity for me to call to every people who are able to contribute to say that this is still open. And Natalia knows that you need money if you want to do sexual and reproductive health in countries. And this is an opportunity for me to highlight it. And thank you.
Thank you so much. And Bebel, the last minute goes to you on the priorities of Germany in moving forward this agenda of always linking sexual and reproductive health and rights into the UHC agenda.
Well, I try to be very brief because both my previous speakers pointed out the very, very crucial points. What we are doing is on two levels. I just want to point that out. What we're doing bilaterally, because for us it's so important to work with partner countries with their own commitment, like Madam Minister was pointing out, their own ideas, to work with partner countries and support if it's wanted or needed in a certain way. To do that bilaterally, we have an initiative on rights, on a rights-based planning of material health, which is combining or bringing together all the bilateral initiatives we are having. And it's a sum amount about 100 billion. It's billion? Yeah, it was billion. Yeah, million. Well, billion was a little bit too much. It's Sunday morning. 100 million euros. So we try to combine that and learn from the various aspects in all the countries we are working with. It's about what I was saying before. It's about social protection. It's about access to health system. It's about being very inclusive and being building on what is the ideas in the partner countries. So that's quite clear. And I don't think I have to add anymore why we are financing also multilateral funds like GFF, IPPF for Planned Parenthood, for example. But Natalia pointed out why it's necessary to support UNFPA, and you made it quite clear. And I think you made it also clear for our taxpayers how this engagement is so important to really give women the right. It's about the right. It's about female rights. It's about human rights. So my minister she's in Washington today and therefore can't be here. She was announcing that with a press release today, so I do it here. But this year we give to UNFPA 57 million. 50 million will be for Ukraine, and additional 2.3 to UNFPA supplies, and 3 million to the maternal health care. So we want really to support what you were pointing out. It's about the topics. It's about not the money only. It's about what you were explaining so brilliantly. And therefore, I think it's the call for action to everybody who can afford that.
Well, what a wonderful note to end the panel on, a note of commitment, because commitment backed by funding will move mountains. Thank you so much. And thank you to all the panelists. And I bring in Anshu.
Thank you very much. And that was a wonderful introduction, I think, or opening part of this session for today. And I just want to applaud Helen, our Marie, and Natalia, and the State Minister or Secretary. Once again, it was really... I wanted to come to Helen's point about gender balance. And of course, nothing can change if men are not involved. And luckily, what we can see nowadays around the world, when there are demonstrations, that we see men are actually also on the street and fighting for women's rights. So I think that there's definitely a glimpse of hope. And therefore, to kick off, I think we had a wonderful panel, but we want to also hear from young people. And we're therefore going to kick off with two speakers who are going to be online from Zambia. And we see that we have Maria and Irene. I think you're together in the same room. Is that correct? Yes, we can't hear you. So
yes, we are.
Thank you. So maybe just to introduce Maria and Irene, we have Irene Ntoka, sorry, who is the Advocacy, Communications and Media Lead for Family Development Initiatives. And there she is coming into the camera. And we have Maria Kanawila, who is the Communication Lead of Dawa Health in Zambia. And they're going to make some some points, let's say, on what is important for them as young people. And so I think I'm going to start with Irene. And Irene, as young people, what is it that you need the most to take care of your own health?
Thank you so much. So responding to the question of how young people can own their own health, most importantly, young people need information, but not only information, but appropriate and age-appropriate information that can help them make informed decisions about their sexual and reproductive health. But this can only happen if this information is incorporated in schools, but also should be appropriate enough, but also incorporated in schools, in the curriculums, just like indicated earlier, that this can be incorporated in comprehensive sexuality education. So at once they're informed and know about what to do and what not to do, but also where to get the needed information and services that are able to take care of their own health. Secondly, access to free but also affordable sexual and reproductive health services is important, especially contraceptives. We've noticed among the young people in Zambia, there's high rise in HIV cases. This is mainly because young people are not accessing these services for the very fact that they're not easily accessible, but overly priced. So if they can be made available, readily available, that is, and also free, it could be a good thing, because that will, in the end, record positive outcomes, health outcomes for young people. But also has to mention that young people can only manage their health by being mentally stable. This cannot be overly emphasized, because the stability of a young person in itself is good enough to keep up with their own health. So this has to run alongside infrastructure, which should be youth-friendly, of course, but also recreational facilities and also supportive environments and psychosocial support as well to address issues of stigma and discrimination, especially for those that already are unfortunate that they're already suffering from diseases like HIV/AIDS. Thank you so much.
Thank you. Thank you. Thank you so much for highlighting really the access to information, and this should be part of national policies, but also for highlighting what we've learned during the COVID pandemic, and that's the issue of mental health of young people. So Maria, then for you, the next question is, what is your message to the leaders that are on stage here today?
Okay, so in most cases, young people are used as tools for statistics. However, I propose that through World Health Organization, young people will fully be engaged when it comes to developing youth agendas and also addressing prevailing social norms. Institutions like GIZ that are already working on SRHR should constantly convey meeting young people for making these amazing agendas that will protect and help SRH. Then my other message is sexual reproductive health rights are human rights. They're not separate set of rights that should be fought for. Every person, young or old, deserves the primary care of their body in its fullness. There should not be a difference between my sexual reproductive health and my day-to-day care, such as when I have a migraine, when I have stomach pains. I should get the same attention and care in all spaces provided. I shouldn't be judged for wanting contraceptives at a young age, because at the moment in Zambia, there is an ongoing debate whether contraception, the one known as a morning after, whether it would be a prescription-based or over-the-counter. So the world leaders need to mainstream the sexual reproductive health agenda as they strive for global health coverage. Thank you.
Thank you very much, Maria, and particularly for highlighting that young people should be able to decide for themselves what they need.
Yes.
So coming to that, we will now turn to the panel, and I would like to introduce the panel members. First of all, we have the Honorable Dr. Sahar Al-Kawasmi, who is a member of the Central Council for the Palestinian National Council, and she's an OBGYN and has been a member of the Palestinian High Council for Motherhood and Childhood already since 1997. Welcome. We have Lois Pace, who is the Assistant Secretary for Global Public Affairs with the US Department of Health and Human Services. She's responsible for advancing the US international health agenda through multilateral and bilateral fora, and is the Office of Global Affairs lead on setting priorities and policies that promote American public health agencies and interests worldwide. We have Monique Fleder, who is the head of the GFF Secretariat, and before that managed the Health Results Innovation Trust Fund. And she's passionate about innovations and smarter investments to improve women's, children's, and adolescents' health. And we have Masiko Matemvu, who is a young advocate from Malawi and is passionate about advancing rights, especially for the most marginalized. Masiko uses creative art to raise awareness on issues affecting young people, and she's the founder and president of UWALE and the vice chairperson of the PMNCH Adolescent and Youth Constituency. So we have many questions for you, and we'd like to hear from all of you. So I hope that in your responses, you can really stick to a couple of key highlights that you'd like to get across. So Lois, maybe I can start with you. You were a member of President Biden's COVID-19 Advisory Board. During that time, what effects of the COVID-19 pandemic did you observe on the provision of other health services, particularly for sexual, reproductive, maternal, and child health services?
So I won't repeat what we heard from the first panel, just to say that that was true in the case of the US as well, but a few other areas I want to highlight. One is just the basic reality that it was very hard for women in particular to do anything else but care for themselves and the world around them. And usually it was in reverse, right? they're bearing the brunt of this pandemic still on their families, right? And this is sort of the sandwich generation, as we call it. So it's children and parents and everything else in between, and trying to get people to school and otherwise make sure that their lives are managed, meant that other things like wellness checks and cancer screenings and the like were falling by the wayside. So that's something I didn't hear come through. That was absolutely something we paid attention to. In addition to this important topic of gender-based violence as well, I also want to highlight how at risk women in particular were and continue to be in global health emergencies worldwide, mainly because they are in the front lines. But we have to remember that the health workforce itself is not just at risk for burnout, but very real trauma when it comes to sexual exploitation and abuse. And we need to continue to call that out as part of this agenda, and also mainstream that as part of any global health provisions and services, including response to pandemics and emergencies. The last thing I would really want to highlight too is just this issue of what services were lost for youth and adolescents. And just to personalize it, I think about myself. I think about what I needed at my age of sexual debut, and the fact that I was receiving counseling and services in school settings. This wasn't something I was able to get in my home setting. And I think about being someone who experienced teenage pregnancy and having resources at hand that weren't available to young girls during the pandemic. And I don't know what I would have done in that circumstance. And so those are the highlights that I would bring to bear in response to that question, but really appreciate this conversation.
Thank you very much. Thank you very much, Lois, and particularly also the issue about providing services in schools, because that's another thing that really stuck out during the pandemic. So Monique, having listened to Lois and the previous panel, your reflections on how this has had an impact on GFF programming and what you have been able to do to support countries.
Really pleasure to be here today and talk about this incredibly important topic. And so when COVID happened in the 38 partner countries where GFF is active all across the world, we very quickly started hearing concerning reports around the disruption in primary care services. And over time, we've been able to document that in quite some detail. And on average, countries experience a 25% disruption. And so 25% of women and children not being able to access those services that they need as part of a comprehensive package of services. But it gets worse, as we also were seeing a really severe increase in financial barriers. And so before COVID, it was already hard for a lot of women and children to financially access services. And this became a lot worse. And this particularly for those households that are most vulnerable. For example, we saw a very large increase in these financial barriers for female-headed households. And so I think a lot has been said already around what are the causes of this and the issues we're seeing in primary care facilities. But I wanted to really highlight the needs and the specific impact this had on adolescent girls. And so we're not just talking about difficulty accessing services. We're talking about a situation in which you also no longer can go to school, in which there are issues around nutrition and gender-based violence increases. And so you can imagine for those girls that were 14, 15 when this happened, what the impact is on the rest of their lives. And a lot we can do to mitigate, and I'll talk more about that in some of the upcoming questions. But really this particular group of people of girls worries us a lot, given the impact and the age group that they were in when COVID happened.
Thank you, Monique. So Masiko, I mean, we heard from Maria and from Irene, and you, of course, have experienced a similar setting in a low-income country, Malawi, contrary to maybe some of the remarks also made earlier about high-income settings, where I must say the issue of social determinants of health has been crucial in identifying, let's say, or in the people who actually got higher rates of COVID infection than others. And so this issue about social determinants, I think that both Lois and Monique referred to, is crucial. But coming to Malawi and how do the messages that you have heard throughout now, not only from Irene and Maria, but also from other panel members, how do they resonate with you, and what actions do you think need to be prioritized for young people in Malawi to have better access to health information and services that are important? Of course, especially talking about sexual and reproductive health.
All right. Thank you very much for that question. And I also just wanted to thank the previous speakers, the young leaders who gave context in what's happening in Zambia, which is also what we also experience in Malawi. I just wanted to start off by saying that achieving universal health access to sexual reproductive health and rights is a key component to achieving sustainable development goals. And even though efforts have been made to address these barriers, we're still seeing, challenges. So in the African region, for example, we have the highest HIV burden globally, with 25.7 million people living with HIV and 1.1 million new infections. This was in 2018. And in Malawi, around 1/3 of all new HIV infections in the country occurred among young people aged 15 to 24 years old. Adolescent pregnancies account for 136 per 1,000 births annually. This was in 2021. And what these statistics are showing us is that there is an unmet need for sexual reproductive health and rights services. And it's very clear that young people have limited access to such services because of different factors, including limited access to information and services, myths that are associated with contraceptive use, religious and cultural constructs, gender inequality, lack of affordability, other barriers to sustained utilization of SRHR services also include attitudes of healthcare workers, for example, long distances to health facilities. And hearing the other speakers, I was really like, okay, we're definitely in different contexts, but then I think that's why platforms like this are important, so that we're also able to give country perspectives of what's happening. So enough of all these problems and challenges. So what must be done? So there's a lot that has to be done, but I'm just going to quickly highlight from my personal perspective on things that have to be done. So first of all, we need to strengthen health financing. And this has to come by holding governments accountable for delivering on their commitments to prioritize adolescent well-being and health. So commitments such as the Abuja Declaration, the ISA ministerial commitments on education, health, and well-being for young people, but then also making approaches and interventions to address access to SRHR information and services, inclusive, especially for marginalized people, young people. And when we talk about building resilient health systems, we're always talking about progressing forward and, building, going more digital, etc. But then as we think of progressing forward, we cannot leave anyone behind. We have to take into account the realities that are there on the ground. And the reality is that majority of the population live behind the poverty line. Majority of the population do not have access to the internet. Majority of the population do not have access to digital technology. So how do we leverage on traditional methodologies and leverage on indigenous knowledge to include that? I know you're nodding your head because you're like, time. So just one more thing as well, because I also do that when I'm moderating, like, come on, 1 minute. Okay, so but then one more thing, which the speakers before had mentioned, is that we need to include young people and decision-making bodies when we're addressing issues that affect them. And young people are not a monolithic group, and we need tailor-suited approaches and interventions for them. And speaking of including young people, we have to adopt a socio-ecological model as we are addressing barriers to accessing SRHR services. So thinking of a care and support for teachers and learning model where you're not only looking at addressing the young person, you're looking at different layers within the community, from the community leaders, traditional leaders, parents, everybody. How do you strengthen and equip those stakeholders with information to address such services? So just to also wanted to emphasize that including young people and asking them what is it that they want and not imposing and guessing on their behalf, because nothing for us without us, because if it's not for us, then it has to be against us.
Thank you very much, Musiko, particularly also for highlighting, I think, that young people are not a monolithic population group. We think that digital health is the future, but we also know there's a digital divide. And so, though on the one hand, many people will be able to access information online themselves, 50% of young people maybe globally will not be able to do that. And so it's really important that this becomes part of national policies, is mainstreamed, is implemented at all service levels, etc. So, maybe coming back now to the issue of social determinants of health. Dr. Sahar, one of the challenges we see is that when we talk about universal health care or universal health access to sexual reproductive health, in many contexts, the access is very unequal. And so, for example, between the rich and the poor, rural and urban, higher education, lower education, etc. Is this something that you have experienced as well, and how have you tried to overcome that?
First of all, thank you for having me here today. I think SRH is very important, and it is a core issue for achieving universal health coverage and also for women equality. Without really achievements in universal health on SRH, nothing can be achieved in both of these issues. And if you want to speak a little bit about the differences, do you know in Palestine we have also different issues. It is geopolitical also issues which reflect itself on the whole situation in general. In Palestine, people who are insured, medically insured, they are about 79%. In Gaza Strip, it is 100%. The governmental sector, it covers 64% of these people who are medically insured. The others, comes from private companies, insurance. Sexual SRH, it is included. Our basket, health basket is very big one, but our resources is very limited. And this is the issue after especially cutoff of clearing proceeds. Now we have a real deficit in the budget. It is half of the budget. Our revenues, it is half. So without support, we can't go forward. And this is maybe which influence on the whole area. For example, in UNRWA, it's giving family planning items for people who are in camps is still persistent in very fixed manner. But the Ministry of Health, it was supported by UNFPA and other UN agencies for especially these family planning items. They stopped or decreased this a little bit since 2014 because they feel that they reached the target of unmet needs decreased to a level that they can quit off. But after that, really unmet needs it raised. After that, I think maybe we still need their support for this issue, and it's a very important issue to continue at least for our projects. Also about maternal mortality, also it is in 2006 what it was about 32% for 32 per 100,000, and in 2015 it was up to 15. Now it is 29 per 100,000. So I think still we need more support from UN agencies in general. Mainly our supporter was UNFPA and the WHO for this issue, and also UN Women and etc. But we need more support for this and to continue their support to have at least stabilization for these parameters in general. About rural, and we have also area C, which is in West Bank. This is 60% of West Bank. It is area C, and it's true in Hebron. And these areas ruled by Israeli till now. So to reach them is very difficult, and areas which is also cut off from the wall. For example, in Jerusalem district, we have many villages which is by the wall. It is cut from Jerusalem. So we have just one hospital, Al-Maqasid Hospital. So when the previously, just to reach Al-Maqasid Hospital, it takes 5 minutes. Now it takes maybe 1.5 hours. Also, we have checkpoints where sometimes, and it was really number of men who has maternal mortality at these cross checkpoints, etc. So I think the geopolitical atmosphere influence, there's a real political will to have more achievement from Palestinian side, and our beds now it can increase more than 3 times. We have previously from 1994 till now, we have previously just primary and secondary health. Now we have primary, secondary, and well-developed tertiary health as specter. We have localized services now, and we have partnership with other sectors like private sector and NGOs toward achieving more cooperation and partnership with them. But lack of resources, it is the issue which really make a real obstacle for our development in this issue.
Thanks very much, Dr. Sahar. And you have mentioned the geopolitical environment. And we've also seen, of course, that due to events globally, food prices are going up, which is going to have a major impact on women and children. But maybe, Lois, I can therefore come back to you, because we know that also SRH is a politically sensitive topic, politically, let's say, and it's under a lot of pressure. And there can be loud opposition to things like contraception and safe abortion, which, by the way, is an evidence-based intervention. Yeah, I mean, the evidence is out there. And particularly so to opposition to things to provide this in healthcare and insurance schemes. What actions do you think are most needed right now to ensure sexual and reproductive rights and health for all?
So this certainly feels like a loaded question for the U.S. representative in the room. So thank you. I mean, a lot is required for us to not just provide, but protect this right for women within our borders, and certainly in other national contexts. I'll say what we are doing. So in light of, for example, the recent Supreme Court decision in the U.S., my boss, the Secretary of Health and Human Services, took action at the direction of the president to ensure that both patients and providers knew their rights. And, for those who aren't tracking, and I think everyone in here is, we're looking at half of our country sort of now being in a situation where people who require access to critical health services, because these are fundamental, half of our country is not providing those, or will soon not provide those in the same way that they have previously. So it's really important for people to be able to understand their rights, to understand their right to privacy, but also their right to access to information and to these critical services, and for providers to feel like they can really do the job of saving lives, because often these are life-saving services that are being missed or lost. So all of that is happening through our Department of Health, working closely with states. I also have to say, just in the global context, because we know that people are watching us and paying attention, and we know that what the U.S. does, for better or worse, still does matter. We're very clear about our stance worldwide, and we remain the largest bilateral funder of family planning services or assistance, and that's on purpose, right? That is not changed, and that's not going away. We also continue to stand in solidarity, frankly, with countries who are on either side of this, both champions and those with which we find ourselves, right, who are still working through some very difficult politics and systems, and we're learning from both of those partners, right? How we again defend, but also how we advance the agenda. So I hope that answers your question in terms of how we respond to this political context. But I appreciate what I'm hearing from this comments is that it can't be in the abstract. And I think what we are wary of doing is hand wringing and saying, oh goodness, the sky is falling. I mean, let's be clear, the sky is falling, or it feels like it's falling. But we can't afford to lose faith, frankly, in what it is that we can do. And while we can hold the line, we absolutely will.
Thank you very much. And of course, next year at the UN General Assembly, we'll have the high-level meeting on universal health coverage. And it's going to be very important to ensure that SRHR is fully reflected within that. So Masiko spoke about health financing. That was her first recommendation. So Monique, back to you then. For WHO, and this statement has already made by Natalia as well, but universal health coverage to health services, including sexual and reproductive health and maternal and child health services, is a human right. Yeah, and half of the world's population lacks access to these services. And one of the bottlenecks is to achieve universal health coverage. And the issue of sustainable financing is crucial to that. So it's clear that we need to reduce the reliance on donor financing on the one hand, and move towards greater domestic financing and greater domestic ownership of this agenda. So how is the GFF supporting this in countries that you're supporting?
Great, thank you. Thank you very much. Really fascinating conversation, and I'm hoping very much that in these circumstances where we have so much pressure on women's rights, we can come together even stronger than before. And I do see a lot of momentum also in the US for that. So great admiration for the work that's being done on this. So I just wanted to go back a little bit and talk about how GFF finances on country level, and then answer your question specifically on domestic funding. And so in all of our partner countries, currently 38, we fund with at the core this really solid, high quality package of services that's delivered community-based frontline primary care services. And so that's the core. And to be able to deliver that, we finance addressing some of the systems bottlenecks, so human resources for health, supply chain, etc. And that also includes, of course, the financing of contraceptive, high quality availability of contraceptives. And we do that by supporting also then an enabling environment. Like, for example, we do a lot of work on national level legal and policy reforms to support SRHR. In Niger, for example, we worked on a legal reform that allowed for SRHR education in schools. And that's just one example of the many ways we support a national level legal changes. We also fund, and we've recently expanded that quite a bit, the work of women and youth-led organizations in GFF partner countries. They play an essential role in the community mobilization that they do, and the work they do around accountability and transparency of financing is really very, very important. So then when I come to the issue of longer term financing, that's very much built into the model of the GFF. And so we look from the start with ministries of health and finance, what are the national priorities? How can we coordinate and come together and align as partners around those priorities? And how can we from the start think about and work with the national governments to increase domestic allocations for this important agenda over time? And there's one issue there in particular, or two issues that I want to flag. One is that there are a lot of opportunities with current resources to do better and have more impact. And so it's not always just about creating opportunities to increase resources. That's important as well, of course. But for example, moving funding, which we've done in many countries, to the front lines ensuring that there's a direct link between the funding and the results that we're after, and the really, really meticulous targeting of those that are most vulnerable with the existing resources makes a lot of difference. And then secondly, we look at dependency. And so, for example, around the issue of contraceptives, it is incredibly worrying that most of the contraceptives for Africa are being bought through donor funding. And so that's the kind of dependency specifically for contraceptives with the current political situation that we cannot accept. And so it's really important when we look at dependency that we think smartly around using existing resources well, but that we also look at what are we actually using donor funding for, and is it really the best possible choice that national governments in Africa or in East Asia or South Asia are so dependent on the US or the UK or other bilateral donors to buy their contraceptives. And so there are opportunities to work on those issues with ministries of finance. And I think that momentum exists, and it will require really broad support. That's why also, that's my final point, is this is an agenda that no organization can do by itself. And that's also why GFF was created as a partnership, and so work with the UN technical agencies like WHO, UNFPA, the role of civil society, Gavi and Global Funds, the bilateral donors. It's really important we come together around the national level priorities.
Thank you, Monique. And of course, we all feel that it's important that national governments increase their domestic resources towards health. But at the same time, there is also a role for financing from partners. And we have already heard the commitments from both Germany and the US earlier. So I want to come to Dr. Sahar. One of the issues we often have around partner financing is that it's not really aligned or harmonized with national plans and strategies. So from your experience, how can we improve that?
I think the Palestinian issue, it is different from other states. We have a problem here because we are not ruling our natural resources, borders, etc. So the situation is different. But I remember at 2009, we have a conference at Addis Ababa for population. And at this conference, I was at draft committee, and I put item that to have at least 10% for health. This was by me put in. And now in Palestine, we have 13% of our budget. It comes for the Ministry of Health. This is one issue, but our situation is very difficult. For example, we have partnership with private and NGO sectors, and we have now cumulative debt about 1.2 billion for these hospitals, and for these hospitals, they are really in threat of collapse, these hospitals, because of lack of resources. And our Ministry of Finance, the priority for them to give salaries. For the last 2 years, they give 80% of the salaries because there's no real financial resources. We have very big problem in financing all of these issues. In our basket, it includes all fertility and infertility issues, but we haven't these items. Our situation is very limited and very difficult and very complicated. So I think we have to look for Palestine in different way, not like other countries in this issue. I am proud that I am, as parliamentarian, I made a real some steps in the world, not just for Palestine. For example, I remember at 2014, we were at Stockholm. It was also international parliamentary forum or meeting for population and development. And I am the person who raised about universal health coverage because it is supposed to be, and I believe it is. But for example, in our country, where about 80% of people, they are insured, the out-of-pocket money, it is more than 20% and it is catastrophic due to the deficit of medications all the time. They haven't the money to buy medications for the people. So our target is very big, but our resources is very limited. This is the issue. Also, from our point, we make a lot of issues which are that needs a financial issue. For example, once we have a problem about abortion, it was raised in our society, and I am as gynecologist who speak to IFTA at the Ministry of Health to stop some actions were from governmental hospitals. One was the director of Obs and Gyna in our district against abortion. He didn't want to make abortion. He announced that this is in Christianity and in Judaism, they didn't want to make abortion. Why we have Muslims to do it? This is the idea. In our beliefs, at least, and in our policies, it is allowed it, and we do it all the time. So I raised this issue, and we stopped him. We stopped them, and we do a lot of issues. Once, twice, 2 years ago, we have voices comes from some fanatic groups against CEDAW, and I am the only person who stand against them. And I stand against them, and they stopped after that to speak about CEDAW. So we bring a lot of issues which are not related to resources, but also without resources, we can't go forward. We need the resources. We need the political will to make a change. I believe public behavior in peace and stability is different from public behavior in war and instability, especially toward political issues like family planning, etc. So I believe that SDGs must be to be done in a comprehensive way, all of SDGs, and to the core issue to it is sexual and reproductive rights and women health. It is the main issue to achieve all SDGs. This is the way to achieve SDGs, but without having a good environment for this, we can't go forward. This must be in our slogan, no one behind, to be a realistic issue, and all together to work towards this. Thank
you. Dr. Sahar, thank you very much for highlighting that point, why there's still so much need for political advocacy. And as you said, without gender empowerment, we won't be able to achieve the SDGs. Very strong message. You have been talking about out-of-pocket payment. And Masiko, I want to come to you because you also actually highlighted that access to services and the cost of services is a barrier for many young people. Services are often free from a policy perspective, but in reality, there are many hidden costs, for example, for transport, medicines, medical and hygiene products, etc. So how is this being handled in Malawi? And how is this affecting the ability of young people to actually access these services?
All right, thank you very much for the question. I just wanted to give some context. Yesterday, when we were driving into Berlin, I had asked the driver what the minimum wage was here, and he didn't know what minimum wage was. So I tried to explain it to him. But I think from his understanding, he had said that it's somewhere about $2,100 or euros before tax, something like that. But then focusing on the main point, he had asked me, what about in Malawi? And so I'd say the minimum wage is about 50,000 Malawi kwacha, which is about $50 or about somewhere about $50 or $55. And he said, what, lady? You know, he was about to like stop the car and he was literally like, what are you talking about? But I think that's, you know, we look at low income countries and we just look at statistics, you know, but behind those statistics, their faces, their stories, and their real people. And the reality, like I'd mentioned before, is that majority of the population lives below the poverty line. And like you had mentioned, some services are free, but we have challenges like long distances, challenges like going to a health facility and not finding medication and having to go buy it at a pharmacy. So think of somebody, majority of the population living about below $1 a day. having to, it's clearly a burden. But what we're seeing government doing is bringing the services closer to the people, closer to the communities. And like Monique had said, and so have the other speakers from this session and the other session have really highlighted the power of partnerships. And we're seeing civil society organizations coming in to complement government's efforts to bring those services closer to the communities for, you know, people who live in hard to reach areas, people with disabilities, to really try to buffer those challenges. But what I see as the problem is, even though I do personally appreciate partners coming in to support those efforts, after 2 years, 3 years, when the project ends, we're back to square one. So I'm really glad that before I spoke, there was a lot of talk on donor dependency, which is something that has to change. And we can't talk about advancing health without talking about economic empowerment. We need to stop looking at health as just one thing. It's a multi-dimensional thing, and we have to include economic empowerment. Our communities have to be self-sustaining. They have to be financially independent to finance themselves, to be able to not crumble once donors have pulled out. So because of all these challenges, you see that young people are reluctant to go access health services. They would rather just stay and have whatever medical issues and conditions they have. This one time I always work with communities and young people. There was this one young man who was sharing with our youth leader. He wasn't able to go access a health service, and he had an STI that had just worsened, over the weeks. So apart from partners coming in to support government's efforts to bring services close to the communities, I think we really need to start thinking of sustainability. And that's why I talked about humanizing the statistics, because if we did humanize the statistics, we wouldn't just come and say, oh, I'm a partner, we did this after 2 years, and then you leave and we're back to square one. You're not a great partner, great partners. Great partners really think of sustainability, and we can't think of sustainability without economically empowering our communities. We also want to be able to make our decisions without having to consult donors, without having to shift our priorities because of the donors' priorities. We want to be able to make our own decisions, and we can only do that if we're self-sustaining. And we have so many international donors. It can be done. It is possible. It's not a far-fetched dream.
Thank you very much, Masika. And we've got 1 minute left before we hand over for closing remarks to Kenneth. But maybe this issue about project funding and it not being sustainable. Monique, do you have any reflection on that for 1 minute on how we can improve that?
That was a surprise question. Well, so decisions, policies, financing, these are not things that are going to be decided or should be decided in Berlin or in Washington or in Geneva, right? And so we're only going to see sustained change if there's real country leadership, if there's ownership over the decision-making and the priorities that are being set. If instead of looking at we're working on the health sector, no, we're working on making the lives of people better, right? If we can put the people central, if we can acknowledge the importance of communities, that's where change happens. And if we can then, in support, look at the advocacy that is needed to continue under really difficult circumstances in the world to advocate for the rights of women and children. That's what we need. Thank you.
Thank you very much, Monique. We had hoped that we would have had some time for Q&A, but we don't. There was one question that came in online, particularly around the issue about LGBTQI, but I think that Monique, in an indirect manner, addressed that by saying we should put people at the center, and that applies for everyone. We can't leave anyone behind. So in that case, I would now like to introduce Kenneth Prudencio, who is responsible for advocacy at the ASAPSU, or the Association to Promote Urban Health in Côte d'Ivoire, since 2021. He previously worked on advocacy projects in Oxfam, France, with Handicap International and Emmaus Connect, and his work is focusing on advocating for the improvement of government policies for health system strengthening, human capital, and MNCH. He also used to work on advocacy to end infectious diseases such as TB and the national COVID-19 response. And he's the co-chair of the GFF Global Youth Platform. And in this capacity also participates in GFF governance meetings, bringing the youth perspective to these discussions. Kenneth, over to you for closing remarks.
Thank you, Doctor. Greetings, everyone. I'm very honored to be here on this panel with you today. I want to start by thanking everyone here, the panelists, the intervenants, and everyone who, working on these issues for the amazing suggestions, ideas, and experience that you shared today. As the co-chair of the GFF Global Youth Platform, I can tell you that adolescents and young people are working, are shaping policies, are advocating in order to improve policies, strategies for health fundings in the world, in the sectors on SRHR and UHC. This is possible thanks to the space given by the GFF to the CSOs and the young people to make sure that no one is left behind. In order to do so and to try and close this amazing panel, I want to share with you some questions. And this question could maybe be my contribution to the policy shaping that you are doing in your organization. The first one is that are the services made for young people accessible? We talked about accessibility here, and concerning especially PHC, it's important to make sure that these services are closer, are more inclusive, and understood by the communities. My second question would be, are these services you are shaping available? To ensure equity, it's important to understand that quality in the services, in the materials, in the platforms, technical platform within the health centers are working. It's also important to make sure that external factors, issues, crises like COVID-19 don't undermine what have been achieved in youth health. For example, in Côte d'Ivoire and many countries in Africa, when COVID-19 occurred, one of the first services that have been shut concerned the youth health, and that increased the youth vulnerability. My third question will be, are the services acceptable? I'm talking about culture. I'm talking about stigma. I'm talking about religions. These are bottlenecks that constitute, we need to go around these bottlenecks in order to have impact on these issues. My fourth question will be, are these services affordable? We talked about it today, because money is a real barrier for young people, but not only. We think that COVID-19 has made it worse, but we also truly believe that UHC can be a solution among others, but it's a real great solution. Because we need to make sure for the next step, the next years, that no mothers or young people have to choose between going to a hospital when they're sick or put food on the table. These are the 4 A's, the 4 points that I want to share with you. And don't forget something. My colleagues from Zambia and also Maziko have said it. Young people don't want to be seen anymore as sole beneficiaries. We want to be seen by you as your key partners to shape the policies and contribute to the improvement of SRHR and UHC. Thank you very much.